Thank you for the invitation to come and talk today. So following on from the previous presentation, I've been asked to talk about web-based pharmacovigilance as an opportunity really to database and also to track variation in MS service provision. So what I'm going to cover briefly in this talk is just to review pharmacovigilance and actually what can we learn from other disease areas. So this is something that historically we've done very badly in MS, and actually there is a lot to be learned from other systems within the UK. And the regulatory framework in which these exist is changing, and it's very topical at the moment for the EMA. I think we all really have an understanding of why these concepts are important within the MS field. And as was discussed in the last presentation, how can common data collection drive forward services and inform care? So what can we learn from other disease areas? Well, within rheumatology, there are actually very well-established disease registers. And at the moment, the British Society for Rheumatology Biologic Registry has input from every consultant rheumatologist prescribing biological therapies in the UK. It's been there for 15 years, it works. So why, as neurologists, should we invent the wheel? Why don't we learn from what's there? And what this is, it's an epidemiological study. Patients who receive biologics get registered onto this, and it was actually, although it acts as a registry, started as a pharmacovigilance study with the intent always to continue it as a registry. So by tracking therapies that patients receive, the adverse events that they have as a result of, or that may be associated with their therapies, you can then build up a disease registry and actually embed this within clinical practice. This has since been extended to the British Association of Dermatologists, looking specifically again at biological therapies and their use in psoriasis. And at the moment, actually, in order to receive a biological therapy for psoriasis, patients have to be offered consent to go onto this website. So it's fully integrated within clinical services. At the moment, both of these registries are actually paper-based, and I think with the newer developments in MS, we have the opportunity to move away from paper-based systems. We're now primarily using electronic clinical healthcare records in a number of trusts, and actually these can both inform care and allow an imputation of more data. So in terms of biologic registries, and this is taken from the dermatology registry, as you can see, people have to include the monitoring lab results that patients have. This isn't anything additional, it's not asking for additional tests, it's asking for actually what is done as part of routine clinical practice and what should be done to monitor patients on these therapies. These results are then logged, stored as part of the registry data. Do these studies fit into a wider framework? And well, the EMA have developed an increasing interest in registry and registry-associated data for use in pharmacovigilance over the past few years. The EMA actually have a set of disease registries, so disease-specific registries, and this is actually available online. And what they define these is an organised system using observational methods to collect uniform data. And it's defined, importantly, it's defined by disease rather than exposure to specific medications with patients excluded. So the EMA have a particular interest in disease or patient registries, so collecting everybody with, for example, multiple sclerosis into a registry, both European and also using initiatives from outside of Europe. Specific pharmacological funded product registries are actually excluded from the EMA's evaluation. And as you can see, there's a number of registries across therapeutic areas, and within neurology, there's 6 registries that the EMA are currently aware of and currently evaluating, and these include MS base within their number. So the EMA has actually a particular interest in multiple sclerosis registries at the moment, and they held a registries workshop a couple of years ago to think actually about how can pharmacovigilance focus, or how can disease-focused registries input into pharmacovigilance, and how can they input into the wider regulatory framework across Europe. And there is an existing tension and about the overlap between a disease-specific registry where clinicians impute data and what the regulators require. And one of the outcomes from this meeting was really an attempt to create a harmonised list between what is practical as a clinician, actually what can you enter into a registry as a clinician, versus what do the regulators want. Because if you go out and you ask regulators what they would like in an ideal framework, the shopping list goes on to 10 pages. If you go out and ask a clinician what in a clinic, in an NHS clinic, what can you impute into a registry, you get about 3 answers, which is normally patient, age, gender and diagnosis. And actually anything additional to that, there is an awareness from the EMA that the amount of data places a burden on the clinician, and the more you ask for, the less reliable your data is. So within in MS, where does pharmacovigilance sit? Well, there is an evolving DMT landscape. I think as everyone in this room is aware, both the number, the complexity, the monitoring, the oversight of disease-modifying therapy in the last 10 years has just increased exponentially. And I think Joella's slide about the number of patients on DMT within a single service essentially doubling over 10 years is illustrative of what's happening around the country. Also, within this increase in patients on DMTs, we've got a huge increase in individual level risk-benefit decision-making. When we're faced with patients in clinic, actually, how do you talk about risk? How do you talk about benefit? And we don't really have a clear handle on pharmacovigilance in MS, certainly within the UK, but actually internationally. And we need to be collecting data around this to inform decision-making. It's accepted throughout regulatory systems that the current systems of yellow card reporting of product-specific registries actually miss a lot of data. People don't record things in yellow cards for various reasons, and product-specific registries miss information around cumulative risk, washout periods, all of the complexity that actually occurs on an individual patient level. And this is only increasing as we put patients on treatment earlier and earlier and earlier and have lower thresholds to treatment switching. As I mentioned, there's a degree of tension between the level of detail that is desired by regulators, and this, I think, feeds in as well to the reporting systems where people report and then they're asked for large amounts of data, and this creates workloads. But that also is there is tension between that and the ability to gather data on a large number of patients as part of routine clinical practice. If you're going to collect pharmacovigilance at a national level, then you need to enter every single patient, ideally. You need to be collecting data on all of these patients, and to collect very high level, very detailed data on a large number of patients is simply not practicable within our current frameworks. So one of the questions around setting up pharmacovigilance is how to ensure the rigorous detection of uncommon events, really with a minimum core data set that's both useful for pharmacovigilance but also as part of wider information gathering. So how would a pharmacovigilance study work in MS? And this is something that I've been looking at over the past couple of years or so. So we are setting up a study. It's to ascertain outcomes for a large cohort of MS patients who are treated with disease-modifying therapy as part of a registry-based initiative. And this is to collect serious adverse events over the intermediate term, but also to capture data that is useful in terms of long-term treatment benefits, in terms of relapse, EDSS, although we all accept that there are problems around collecting EDSS. And what this carries within it is the potential ability to assess the effect of treatment switching, of washout periods, but also to drive forward improvements in service. Because when you look at what kind of data we might be collecting as part of this, it's actually a relatively minimum core data set with NHS ID, MS-specific data that you would normally expect to be collected or gathered in the routine clinical appointments, and treatment information. And actually longitudinally, what will we be collecting? Well, current disease-modifying therapy, details of changes, 6-monthly or other monitoring bloods, and then adverse events and any new diagnoses. And really, the question here is, what is the value for patients? As Neil said in the previous talk, we are asking patients to give an awful lot of data repeatedly, and what is the benefit for patients? You can ask people to give all of their information, but why? And I think particularly relevant to today is actually moving towards standardised care for people with MS. Well, how does a structure such as this or any other registries initiative move towards standardised care? Well, if you are asking people to collect data on a regular basis, then you're asking them to see the patients, collect that data, and actually through a study format you can incentivize data collection and follow-up. So we can use the lessons that we have learned from rheumatology and dermatology in terms of collecting minimal data sets that are used anyway in within disease-modifying therapy monitoring. And actually this is in keeping with the national guidelines for clinical monitoring, so asking people for an annual review, ensuring that everybody gets an annual review with data and follow up if that data is not entered. And again, collecting safety monitoring data, not in excess of the monitoring schedule, but actually in keeping with what is being demanded by regulators. And the additional advantage of doing this within a study format is that it allows clinicians to utilise existing infrastructure to leverage research support, so the NIHR and the CLRN portfolio studies, and research studies to actually enable us to gather longitudinal and follow-up data. So how does this kind of study reduce variation in MS care? Well, it provides systems to support care. And one thing that I think is key is that actually most generic electronic health records that we use in daily practice within hospitals don't allow customization. They're very set within the provider and actually have limited functionality for both scheduling and alerts. And one question that comes up repeatedly is, well, with the monitoring, can this be automated in order to really standardize care to make sure that everybody's getting the bloods, the monitoring that they need? And actually, if patients are starting to default, how people are alerted to that in a system that is currently extremely stretched. And actually, by the use of MS-specific electronic healthcare records, allowing clinical, radiological and blood monitoring to be integrated within the clinical record, then this allows us to actually track variation and see who is getting monitoring, what is happening when, and using a common language. And I think the final key is that clinicians won't use a system that doesn't help them. If it's not useful to you in your clinic on a day-to-day basis, nobody will do it. So actually designing a system that both aids clinical care but also reduces variation is key. So I think in conclusion, I'd summarise by saying that registry-type studies, wherever they originate and whatever their purpose is, provide an ideal basis for recording aspects of care in a systematic manner that can then be used to both assess and track variation. But they are dependent on every patient or every consenting patient within centres being enrolled into that, so there has to be clinical utility. And adoption of routine recording is vital, and really the keys are how to make this practical within our current NHS climate where everyone is already overloaded. So embedding pharmacovigilance or other clinically useful studies within this will allow us to incentivise data collection. So we're currently putting the ethics applications going in this week. So
and how many centres have signed up across the country?
So we've got 11 centres in the first rollout. And I think I know there's some people from some of the centres here today. So thank you.
Yeah. So just to say that we actually went to the ABN with all the proposals to actually clone and copy the Biologics one about 7 years ago, I think it was. And for various legal reasons, we couldn't set it up back then. So this is a we could have had this thing now running for about 7 years already. So, Monica, question at the back. Rachel.
I still see that there is duplication.
Yeah.
So how do you want us to work with that when we're already doing that for the MS register, for example?
Yeah, so I think there is data, and certainly with the way optimised has been designed, it's been designed so that actually the back programming language will talk to other registers, other data, to allow sharing of data across registers where patients consent. But yeah, absolutely, there is duplication, and I think working together is the only way to reduce that duplication and that duplication of workload, which is the key thing to avoid.
Neil?
So one of the things that we've struggled with in terms of utility is that it's become increasingly important to embed results within the system. Now, you may be able to do that at your hospital, but you're going to have to negotiate it also separately for every other hospital in order to generate utility. So that's a significant problem. And the other thing is that if you can't actually suck up the data and put it in your system unless you've got a license for this as a clinical tool. So you can only window it in. So you can only mirror the data in your stuff. So one of the things that I would really like to see happen from all of this is for IT systems in NHS hospitals to understand that modern MS management needs these kind of systems to effectively manage it, and not to block the idea that we can actually access those kind of data which will improve patient care. Because trying to negotiate this with NHS IT is a blooming nightmare. Well, it is for me, but you may have got a solution.
I have no solution for NHS IT. So in terms of the use of things as a clinical tool, we have been to and fro with IT governance and the MHRA around this, and really the key lies around whether you are using this as an audit and data tracking tool, in which case it doesn't come under MHRA regulations, or whether you intend this to be used as a decision aid. And it's actually, that's where the language lies with the MHRA at the moment. Yeah, that's the complicating factor. But the intent is of the registry is away from that.
Just a quick question. So we don't consent to put patients onto Bluteq. So why do we have to consent for all these databases?
Study. That's
because for registries that are out with direct clinical care or out with the NHS, we have to consent everyone for.